We are discussing management of ovarian cyst in premenopausal women. So I was mentioning that CA 1 to 5 has limited role in premenopausal women. So now we will um, we were talking about CA 1 to 5. And we were in cases in the case conditions which increase or decrease the CA 1 to 5 level. So limitation of CA 1 to 5 in premenopausal women. A serum CA 1 to 5 assay is not necessary when a clear ultrasonographic diagnosis of simple ovarian cyst has been made. If everything is normal, cyst is normal, no increased risk of family history of ovarian cancer, and no history of weight loss and no ascites, then we are sure that this is simple cyst, and then CA 1 to 5 is not required. If we do the CA 1 to 5, there's any complex cyst or anything suggesting towards the cancer, we will do CA 1 to 5. If it is raised, there are two chances that it's raised but less than 200 units. And in the second scenario, CA 1 to 5 level are raised and more than 200 units per ml. So if it is raised but less than 200 units per ml, further investigation may be appropriate to exclude or treat the common differential diagnosis. Because if it is raised but less than 200, there are less chances it's a cancer. So there can be other condition which causes increase in CA 1 to 5. So we will do serial monitoring of CA 1 to 5. So when we will serial monitoring of CA 1 to 5 may be helpful, as rapidly rising levels are more likely to be associated with malignancy than high level which remains static. If it's raised less than 200, let's say it's 150, and we do the serial monitoring, it's still 150, 150. So it means it's not cancer. If it will be cancer, it will increase with the time. And in second scenario, you did the CA 1 to 5, it's more than 200. So there are chances that she is having the cancer. So discussion with gynecological oncologist is recommended. This is the discussion about CA 1 to 5 in the premenopausal woman. And the role of, now we will do the TVS. As we know, in the postmenopausal group, TVS is a single most effective way of evaluating ovarian mass. Same in the premenopausal woman. So with transvaginal ultrasonography being preferable due to its increased sensitivity over transabdominal ultrasound. We can use transabdominal ultrasound along with the TVS. If cyst is too large to be evaluated by TVS, huge cyst, then we will supplement the information with the help of transabdominal ultrasound. So repeating ultrasound assessment in the post-menstrual phase may be helpful in case of doubt. No single ultrasound finding differentiates categorically between benign and malignant ovarian masses. You cannot pinpoint that this, if the patient is having this finding in the cyst, it's definitely benign or malignant. So is there any role of routine use of CT and MRI? As I have mentioned in the postmenopausal woman, same is here. If you do, it's not routinely used because it does not improve sensitivity and specificity obtained by transvaginal ultrasound in the detection of ovarian malignancy. CT scan is only required when you assess the cyst and you are suspecting it to be malignant. So you will arrange CT scan and you will refer the patient to the gynecological oncology services. And MRI is only indicated if TVS is inconclusive, then you can do MRI. These are two questions being asked in exam. What is the best way to estimate the risk of malignancy? Routine use of CA 1 to 5 assay in investigation of premenopausal woman with an ovarian mass has not been shown to be useful because of its relatively poor sensitivity. At present, the risk of RMI1 is most widely used model, as we know, in the postmenopausal woman, but ultrasound rules derived from International Ovarian Tumor Analysis Group, IOTA, to have increased sensitivity and specificity. So RMI is simple to use, no doubt it's simple to use and reproducible, but its utility is negatively affected in the premenopausal woman. And why? Because CA 1 to 5 level is used to increase in this group of patients, in these group of patients. This is primarily because of the incidence of endometriomas, borderline ovarian tumors, non-epithelial ovarian tumors, and other pathology, increasing the level of CA 1 to 5 in this group. NICE guideline on ovarian cancer recommends that for women with suspected ovarian malignancy, the RMI1 score should be calculated and used to guide women's management. So how we calculate the RMI1? It's already I discussed in postmenopausal guideline as well. In the RMI1 combines three pre-surgical features in which we will measure CA125 level. Its level can be as low as 0 and as high as hundreds or even thousands of units. Then we will multiply it with the menopausal status. Menopausal status, if patient is premenopausal, then score is 1. Is postmenopausal, score is 3. See, and ultrasound result. In ultrasound, we see like characteristic multilocular cysts, solid areas, metastasis, ascites, and bilateral lesion. If any of one of these, if no feature is present, then ultrasound point is 0. If one feature is present, ultrasound point score is 1. If two are present, then ultrasound score is 3. There is no 2 in the RMI for menopausal status and from the ultrasound finding. So is there another way to estimate accurately a risk of malignancy in premenopausal women without using a CA125? Yes, there is another way. There are simple ultrasound rules derived from the IOTA group. Using these rules, the reported sensitivity was 95% and specificity was 91%. Women with the ovarian mass with any of the M rule ultrasound findings should be referred to gynecological oncology services. So what are these B rules and M rules? B rules, unilocular cyst, presence of solid components where the largest solid component is less than 7 mm. So I have mentioned it that if it is 7 mm, it is M rule. Less than 7 is B rule. Presence of acoustic shadowing and smooth multilocular tumor with the largest diameter less than 100 mm. If it is equal to 100 mm, it is M rule. Equal to 100 or more than 100. No blood flow on color Doppler. M rules, irregular solid tumors, ascites, at least 4 papillary structure. If there are 3 papillary structures, it is not an M rule. It should be 4 for the M rules. Irregular multilocular solid tumor with largest diameter equal to or more than 100 mm. Prominent blood flow on color flow Doppler. So what is the management of simple ovarian cyst? Women with small. Now we will manage the simple ovarian cyst. I'm mentioning simple ovarian cyst according to size. So if it is less than 50 mm diameter, simple ovarian cyst generally do not require follow-up, as these cysts are very likely to be physiological and almost always resolve within 3 menstrual cycles. You do not have to repeat the ultrasound for these types of simple ovarian cyst. But if there is a simple ovarian, I'm talking about only simple ovarian cyst according to size, but not the complex. Women with simple ovarian cyst of 50 to 70 mm in diameter should have yearly ultrasound follow-up. Those with the largest simple cyst, more than 7 centimeters, should be considered for either further imaging or surgical intervention due to difficulties in examining the entire cyst adequately at the time of ultrasound. So you need to see the largest simple cyst, why it's so large, above 7 centimeter. If it is 7 centimeter and 5 to 7 exact size, then these are for 1 year follow-up. If more than 7 centimeter, then you will do MRI to completely evaluate, and or you do the surgical intervention to because you want to see whether it is not borderline ovarian tumor, because borderline ovarian tumor may appear simple cyst on the ultrasound finding preoperatively. How should persistent and asymptomatic ovarian cyst be managed? If ovarian cyst that persist or increase in size, but it's simple ovarian cyst, but increasing or persisting, not after yearly follow-up, you see it's still 5 to 7. Why it's not resolving? So if it's simple, it should resolve, because we are scared of borderline ovarian tumor. So ovarian cysts that persist or increase in size even after 1 year or are unlikely to be functional and may warrant surgical management. Mature cystic teratomas, dermoid cysts, have been shown to grow over time, increasing the risk of pain and ovarian accidents. So surgical management is therefore usually appropriate. The preoperative assessment using RMI1 or ultrasound rules, IOTA group. There is no evidence-based consensus on the size above which surgical management should be considered. We cannot say that above 6 or above 7, we always do surgical management. But most studies have used an arbitrary maximum diameter of 50 to 60 mm along their inclusion criteria to offer conservative management. Most studies have said 50 to 60 are fine up to for the conservative management. Okay, combined oral contraceptive pill. We used to think that combined oral contraceptive pill, if there is simple ovarian cyst, we will give it for the 3 months and we will repeat, it will go away. No, there is no role of combined oral contraceptive pill, because if it's benign and it's small, it can go on its own. You don't have to give contraceptive pill. And if it's a large cyst, it will not help even if you take combined oral contraceptive pill. Combined oral contraceptive pill can be protective in cases of ovarian, if there is a risk of like in BRCA1, BRCA2, or Lynch syndrome, we can give combined oral contraceptive for the prevention of it gives protection against ovarian carcinoma, small protection, but it does not, if there is a cyst, it cannot resolve it. Is the laparoscopic approach better for the elective surgery management of the ovarian masses? Obviously, laparoscopic approach is always superior than laparotomy, but it depends on certain circumstances. Like, we need to carefully choose the patient, and surgeon should have necessary expertise, and the cyst can also decide which techniques it wants. Like, if it's a very large cyst, you cannot take it out by laparoscopy. So, or there is because if we cannot confirm 100% that this is benign cyst, because I have mentioned that in the borderline ovarian tumors, the cyst may appear simple. So if you think this is simple and it is not resolving on its own, and you do laparoscopy and you spill the content of the cyst inside the abdomen, then it's not good for the patient. So if it happens, you need to thoroughly do the peritoneal lavage. So laparoscopic approach for elective surgical management of ovarian masses presumed to be benign is associated with lower postoperative morbidity. Shorter recovery time is preferable to laparotomy in suitable patients. Laparoscopic management is cost effective because of associated early discharge and return to work, like enhanced recovery program. In the presence of large masses with solid component, for example, large dermoid cyst, laparotomy may be appropriate. You cannot take out large dermoid cyst by laparoscopy, because there are solid components as well in the dermoid cyst. Who should perform laparoscopy surgery for the presumed benign ovarian cyst? This is the surgeon expertise. Laparoscopic management of presumed benign ovarian cyst should be undertaken by surgeon with suitable experience and appropriate equipment wherever local facilities permit. So, role of aspiration of ovarian cyst, either vaginally or laparoscopically, is less effective and associated with the high recurrence rate. Recurrence rate after laparoscopic needle aspiration of simple cyst range from 53% to as high as 84%. In the postmenopausal group, we have studied that 1 in 4 cysts will recur. So here, recurrence rate is even higher than the postmenopausal group. So it is important to avoid unplanned rupture of the cyst. Spillage of cyst content, as I have mentioned, should be avoided where possible, as preoperative and intraoperative assessment cannot absolutely preclude malignancy. Consideration should be given to the use of tissue bag to avoid peritoneal spill of cystic content. Bearing in mind is the likely preoperative diagnosis. Inadvertent spillage inadvertent spillage does occur, meticulous peritoneal lavage of the peritoneal cavity should be performed using large amount of warm fluid. When should an oophorectomy be performed? The possibility of removing an ovary should be discussed with the woman preoperative, because if they see that if there is you remove the cyst and there is a bleeding which cannot be controlled from the ovary, then there's a risk of removing the ovaries there. Thank you so much. You can study these two guidelines together, ovarian cyst in the pre and postmenopausal women. So you can differentiate between two guidelines. And if there is any more questions, so you can write in comment. Thank you so much.